One, two, three. 3 out of 100 patients with a prosthetic valve will have a serious complication. Not in his lifetime, but in 1 year.
Always keep this statistic in the back of your mind when you recommend valvular surgery to patients. We're just exchanging one disease state for another. Of course, we can argument that we can also perform mitral valve repair, at least in the setting of mitral valve disease. But then you can never be 100% sure that the patient will not awake with a prosthetic valve.
But for which complications do we have to look out for? Well, that also depends on what kind of a valve we have. Is it a mechanical or a biological valve? In mechanical valves, we have to look out for left ventricular failure, paravalvular leaks, valve obstruction caused by thrombus or pannus, endocarditis, and structural failure of the mechanical valve itself. In biological valves, again we look for left ventricular failure, also for paravalvular leaks, but also for valvular regurgitation, valve obstruction, now usually caused by degenerative disease, and also for endocarditis.
Now my question to you, from the list I showed you, which of these complications do you think is actually most frequent?
It is left ventricular dysfunction. Not necessarily will the patients present with acute symptoms, but they will gradually develop signs of heart failure. Why does left ventricular failure occur in such patients in the first place? One of the major problems is that surgery was performed too late, and that there's already been some irreversible damage done to the left ventricle. It could also be a result of surgery. For example, the patient had some form of ischemia during surgery or some myocardial damage. And it could also be a consequence of complications such as paravalvular significant regurgitation or residual valvular dysfunction. And here's a graph which shows you how frequently other complications of prosthetic valves occur: bleeding, structural failure of the prosthetic valve, and paravalvular regurgitation. If we compare how frequently bleeding occurs between mechanical and biological valves, we clearly see that it is more frequent, obviously, in mechanical valves because these are the patients who are under warfarin. If we look at structural failure, we do not see that in mechanical valves. Remember, we already mentioned how robust such mechanical valves are when we talked about the types of valves. It's a different story with biological valves. Such valves can show degenerative changes and show structural failure. In contrast, paravalvular regurgitation is a bit more common in mechanical opposed to biological valves. If we come back to structural failure and compare how frequently it occurs in the mitral and in the aortic position, we can see that structural failure is more prominent in the aortic position. I would assume this is related to the fact that prosthetic valves in the aortic position have to withstand higher pressure gradients and higher velocities and thereby more stress. But aside from the position where the valve is implanted, other factors also seem to play a role. Other predisposing factors are renal failure, hemodialysis, hypercalcemia, adolescence, so the growing patient also has a higher risk of structural failure. Therefore, we should not implant biological valves in patients who are fairly young. And it also seems as if pericardial valves are more durable than porcine valves. Here's a beautiful example of a biological valve which shows structural failure and obstruction. The key findings here are thickened and calcified leaflets and a reduced mobility of the leaflets. In such patients, you will find elevated gradients and also a fairly long pressure half time, just as you would in patients who have mitral stenosis. If you see such patients, always ask when the valve was implanted. Such changes don't happen overnight. The normal lifespan of a biological valve is somewhere in the range of 12 years. Don't expect to see such changes before maybe 4 to 5 years. if you have high gradients across a prosthetic valve, especially in the setting of no structural changes, always ask yourself the question if it is maybe a patient-prosthesis mismatch. Here's another example of a patient with obstruction of a biological valve, and here you can see a typical sign that we see with color Doppler. Turbulent inflow, the typical candle flame. Remember we saw that already when we talked about mitral stenosis? Well, here it is again. And the way we quantify the severity of obstruction is also very similar to the way we quantify mitral stenosis. We look at the mean gradients and at the pressure half-time. Here are the Doppler tracings of the patient we saw previously, and here we calculated a mean gradient of 14 millimeters mercury, which is significantly elevated, and a very long pressure half-time of over 170 milliseconds.
Watch the following demonstration of a patient who has obstruction of a biological valve and see how we can use both the 2D image and the continuous wave Doppler to evaluate the valve. This is a patient who received two prosthetic valves, an aortic and a mitral valve. Both are bioprosthesis. Let's now take a look at the mitral prosthetic valve first, and we can recognize that it must be a bioprosthesis because we have the struts located here and here. But what is nice to see is that there is severe calcification and a reduced mobility of the bioprosthesis. So this is apparent here in the peristernal long axis view, but also in the apical views. Four-chamber view showing you again the struts of the bioprosthesis and the severe calcification. You can move the transducer back and forth and thereby try to assess the full extent of the valve. There's reduced mobility. To quantify the severity of the obstruction, what you need is a continuous wave Doppler signal. So this would be the signal. And if we now take a look at the mean gradient by tracing the curve, we get elevated forward flow with over 3 meters, and we get a fairly high gradient of 17 millimeters mercury. We can also try to assess pressure half-time. I'll try to get a nice signal where we can really okay. And if we perform pressure half-time measurement, we get a pressure half-time of approximately 180 milliseconds, which would mean the functional opening is 1.2. In any case, there is obstruction of the bioprosthesis.
So here we have moderate to severe obstruction of a biological valve. A thrombus on a biological valve which leads to obstruction is a fairly rare finding. In contrast to mechanical valves, where thrombi can occur. The metallic housing predisposes for the formation of thrombi. Therefore, we have to anticoagulate all patients who have a mechanical valve. What other predisposing factors are there? Well, if anticoagulation is insufficient, in other words, if the INR is low. Another important factor is left ventricular function. If function is poor, we have slower flow and therefore a higher likelihood for the formation of thrombi. Usually patients with thrombi on a mechanical valve present with stroke or embolism, and sometimes we have sudden onset of symptoms such as dyspnea, which is usually caused by obstruction of the leaflets of a prosthetic valve, and thereby symptoms very similar to mitral stenosis if it is a mechanical valve in the mitral position, or aortic stenosis if it is a valve in the aortic position. The gradients can be very variable. Very often will you find elevated gradients in these patients that fluctuate depending on how bad or how severely the leaflets are stuck. Another cause for obstruction is a pannus. A pannus is defined as a vascular overgrowth which protrudes and grows into the valvular area. Usually it's some form of fibrotic tissue, maybe it's fibrotic tissue which originally was a thrombus. In contrast to fresh thrombus, however, the INR is normal. It shows a rather slow onset of symptoms. It usually occurs only in prosthetic valves which have been implanted several years ago, so older prosthetic valves, and the gradients are more stable. Coming back to echocardiography, what are the key findings? An impaired or stuck leaflet, echogenicity in the valvular region, something that looks like a thrombus, pathological flow pattern with color Doppler, and elevated gradients together with changes in the pressure half-time if we're evaluating a mitral valve prosthesis. This is a perfect example, a TE study where we see all the features I previously mentioned. A stuck leaflet, the echogenicity in the region of the valve, the thrombus, and elevated flow, the candle flame, remember? We also see that no flow goes through the valve in the region where we have the obstruction, and we also have slow flow caused by the obstruction. This, however, is usually not visible as nicely from a transthoracic approach. There, it will usually be the gradients which help you. In mechanical aortic valves, it's much more difficult to visualize a thrombus or a pannus. This is true both from the transthoracic and the transesophageal approach. So the morphology is usually not of as much help as in the setting of mitral valve prosthesis. There we have to rely more on the symptoms and on the Doppler findings, in particular the elevation of the velocity and the gradients, and we can also use the Doppler velocity index. In prosthetic mitral valves, we should suspect obstruction if we have gradients above 6 to 8 millimeters mercury and a pressure half-time above 130 milliseconds. In the examples I showed you so far, I think you can appreciate that echocardiography is capable of visualizing the opening and closing motion of mechanical valves. However, it is much less sensitive and specific than fluoroscopy. I'm sure you'll agree, just looking at these two valves, this is the one who has the problem. Here we have a leaflet which is stuck in the open position. So fluoroscopy is a very, very valuable adjunct to echocardiography. And if you have the suspicion that something is wrong with the valve, that there is obstruction, you have elevated gradients, you can obviously, or you should also perform TE, but you should not forget to also perform fluoroscopy. Now I'd like to talk about the next possible complication of prosthetic valves, regurgitation. Well, bit of regurgitation is not uncommon both in biological and mechanical valves. We talked about that already, especially with respect to mechanical valves. But pathologic regurgitation can occur, and what we now have to differentiate is it paravalvular or valvular? If it's valvular, we then have to determine, is it caused by structural failure in the setting of a biological prosthesis, or by mechanical failure? In other words, if we have some problem associated with the function of a mechanical valve. A very rare situation, but a situation which can occur. Perivalvular regurgitation is a fairly frequent finding right after surgery. However, most of these leaks close after time, so if we look at these patients later on, we find much, much less perivalvular jets than we do initially. Determinants of perivalvular regurgitation are a calcified annulus and endocarditis, both situations where it's difficult to suture the valve, and also the type of suture technique which was applied.
Let's now go back to the patient we saw previously and see if we can also find regurgitation. So let's go back to our patient who had the two prosthetic valves and again focus on the mitral valve, but this time let's look at the color Doppler signal. So in the parasternal long axis view, what you will immediately see is that there is a turbulent inflow, which is not surprising since we know that the patient has
inflow obstruction caused by the degenerative changes of the bioprosthesis. But what we also see is we see that there seems to be regurgitant jet here located right here, which seems to be directed towards the anterior wall of the left atrium, towards the aortic root. Difficult to assess the severity of regurgitation here, but it is certainly at least moderate, probably moderate to severe. To get a better feel for regurgitation, we'll look at the apical views. And this is the apical view with color now, where we see the regurgitant jet. However, it's quite difficult to see here, simply because we have a lot of calcification here, and we do not see the atria very nicely. So in this case, it's good to move the transducer and look at different angles and different positions. And if you play around a bit with the angulation, you will then also see the regurgitation in a 4-chamber view here. So this is probably severe regurgitation, even though we do not see the vena contracta. There's another indicative sign. This is the continuous wave Doppler spectrum we saw previously with the very high gradients. So the high gradients are not only caused by the obstruction, but certainly also because we have regurgitation and there's pendulous flow going back and forth through the mitral valve.
Here's a list of things for you to consider to make it easier for you to find valvular or paravalvular regurgitation. First of all, always use multiple views and atypical views. This is such an example. This is neither a 4-chamber view nor a short axis view. It's kind of a tilted view somewhere in between. And here you can see the jet very nicely. Why? Because many of these jets are eccentric. Also use short axis views. Use the continuous wave Doppler. I'll show you an example later. And the gradients can be indicative also for the presence of elevated flow across the valve and therefore for paravalvular or valvular regurgitation. Aside from the echo, also use clinical information. Does he or she have symptoms? What about hemolysis? And how is left ventricular function? Here's a beautiful example which shows you at least moderate to severe, probably severe paravalvular regurgitation. We can see that the jet arises from the ring or from outside the ring of the prosthesis, and we actually have 2 jets, one lateral and one medial jet. But sometimes, especially in patients who have poor image quality, those jets might not be so easy to see. In this case, sometimes it's helpful to use continuous wave Doppler. Here we have the Doppler sample volume placed right within the jet, and you see a very nice tracing of regurgitation. However, watch out. Such a signal does not necessarily mean you have paravalvular regurgitation. It could also mean that you have the sample volume placed right where the origin of physiologic regurgitation is. But nevertheless, continuous wave Doppler can be of help, especially in situations where you have poor image quality or a lot of color Doppler artifacts. Sometimes you can even suspect paravalvular regurgitation just from the 2D image. This is a transesophageal study where you can see that there's a gap here between the prosthesis and the lateral wall of the ring. And if we use color Doppler, we can see that the jet of paravalvular regurgitation is located exactly in that region. Of course, transesophageal echocardiography is superior with respect to image quality to transthoracic echo. Nevertheless, you will find situations, and I have seen such patients, where we could actually see the gap even from a transthoracic approach. Here we have a bioprosthetic valve of the aorta, and my question to you, is this a valvular or paravalvular regurgitation? Well, looking at the 5-chamber view, we can only say that the jet comes here from the middle, but that does not exclude that the jet is paravalvular because it could be either anterior or posterior. However, if you take a look at the short axis view, you can see that the jet has its origin right here in the middle. So, for sure, we have a valvular form of regurgitation. And the severity? Well, the severity is mild.
In reality, it's often very difficult to really find the origin of these jets. In clinical practice, Very often we cannot really distinguish if a jet is a normal physiologic form of regurgitation or just a very trivial or mild form of paravalvular regurgitation. But then in the end, it does not really matter anyway, because if it's only mild, who cares? So this is the patient following percutaneous implantation of an aortic valve. We can see the aortic valve located here. It's a core valve. Typical appearance of the core valve, which extends far into the LVOT. But now let's take a look at the color Doppler. And we see a small little flame, a jet right here, which originates from outside the vicinity of the prosthesis. You can see that much better here in a short axis view. Again, you see the rim of the prosthesis here. And if we now just put the color, there's just a very small little flame right down here. Probably another flame right up here. But the regurgitation originates definitely outside the rim of the prosthesis. Now let's take a look at the patient from an apical approach. Here again, the regurgitant flow. Very close here to the anterior mitral valve leaflet. Eccentric origin, not very much, probably mild at most. We can take a look at that in the apical long axis view as well. So if we freeze the image here and just take away the color, you can nicely see that the origin is outside the rim. So this is a classic mild paravalvular aortic regurgitation following implantation of a core valve.
Here is a little cheating chart that you can use to interpret elevated gradients. First, ask yourself the question, is flow maybe elevated? You look at the LVOT velocity, at the flow across other valves, and at left ventricular function. Is it hyperdynamic? Then you search for regurgitation with the help of color Doppler. Next, you ask yourself the question, how large is the prosthesis? Get the information and compare it to the body surface area of the patient. Next question you have to ask yourself is it true obstruction? What is helpful here is to have baseline values. In other words, you see if previous echoes showed a high or low gradient. In mechanical prosthetic failure, you would have a rapid development of obstruction. So you will find a normal gradient on the first exam and an elevated gradient on the next exam. In pannus formation and in obstruction of biological valves caused by degenerative disease, you will find a rather slow increase in gradients. And finally, it's also very important to ask the question, when did symptoms arise? And look at the lab tests. How is the INR value? And is hemolysis present? If you have a prosthetic valve in the mitral position, you can determine whether an elevated gradient is caused by obstruction or by regurgitation with the help of the pressure half time. Is the pressure half time elevated? Then it must be obstruction. Is pressure half time normal? Then it must be regurgitation.
Now I would like to change the topic and discuss an issue which is very important also with respect to evaluating patients with prosthetic valve complications, namely the importance of transesophageal echocardiography, an exam which can easily be done in this individual here.
Well, we talked about the importance of TE already when we discussed obstruction, but it is equally important to detect paravalvular and valvular regurgitation. Here is an example of a biological valve with significant, severe paravalvular regurgitation. But even more important than in biological valves, it is in the detection of regurgitation in mechanical valves, because, as already mentioned, especially in this setting will you have shadowing of the left atrium from a transthoracic approach, and you will not be able to see this region here except with TE. So, it's important not only for the visibility of jets, but also for the quantification of the severity. And TE is also very important in the setting of paravalvular aortic regurgitation. Here's such an example. we have a stented biological valve. Again, you can see the 3 stents very nicely, 1, 2, and 3. And if we use the color Doppler, you can see that we have a paravalvular jet right here in this region in neighborhood to the pulmonary artery. A life-threatening complication of prosthetic valves is partial or complete valve dehiscence. This usually occurs in the setting of endocarditis, and the typical finding with echo is the rocking motion of the prosthetic valve. Here's an aortic valve which shows such a rocking motion, and it's quite apparent that dehiscence also led to significant severe acute aortic regurgitation. The patient had to be immediately reoperated. This is another patient, this time however with fluoroscopy, where you can also see a rocking motion, also in a patient who had partial dehiscence of the valve. Tired? Exhausted? Well, I can understand. But hang on, there's only a few more complications to go. You almost made it. The next complication we'll talk about is pseudoaneurysms of the intervalvular fibrosa. Well, we encountered pseudoaneurysms already when we talked about myocardial infarction in the chapter on coronary artery disease. We will also hear about pseudoaneurysms in the chapter on aortic disease. Now we're talking about a specific location, the intervalvular fibrosa, which can also have a pseudoaneurysm. So remember, the intervalvular fibrosa is the region between the aortic valve and the anterior mitral valve leaflet. What happens is that we have dehiscence at the proximal suture line of the prosthesis, and thereby patients develop an echo-free space between the aortic wall and the graft. Note that there is flow into this echo-free space during systole and back out through the same hole. Therefore, we have pulsatility of the structure. Predisposing factors are endocarditis. It not only occurs in the setting of prosthetic valves, but also in native aortic valves if endocarditis is present. Sometimes we even have a communication between the pseudoaneurysm and the aorta, and thereby we have a fistulous communication between the LVOT and the aorta. What is the relevance of such pseudoaneurysms? Should they be operated? Well, I guess in most cases you can probably just leave them alone, unless they're very large, or if they show rapid progression, or if some form of hemodynamic problem occurs because of the pseudoaneurysm. In any case, one has to follow them with echo. A fairly rare complication is that of a ventricular septal defect, which can occur as a iatrogenic complication or following endocarditis. Here's such an example in a short axis view, aortic valve prosthesis, and here we have the jet which is directed from the left ventricle into the right ventricle, a ventricular septal defect. And now to an absolute nightmare for patients with artificial heart valves. Endocarditis. What are the facts? The cumulative risk of endocarditis within 5 years is 3 to 6%. Biological and mechanical valves can be affected. Biological valves actually more frequently than mechanical valves. It is often difficult to detect, and we usually need transesophageal echocardiography, and it can cause both regurgitation and obstruction. Here are 2 examples. A transthoracic study where the diagnosis could be made. We see a mobile structure here on a mechanical valve, and here is a transesophageal study, again a mechanical valve, a bileaflet valve, where you can see mobile structures and soft echogenic structures here on the ring of the prosthesis. I want to leave you with these 2 examples for now, but we'll come back to prosthetic valve endocarditis in the chapter on endocarditis, which will come next. One last issue I'd like to discuss, which is not really a complication of prosthetic heart disease, but it basically is just an associated finding, which however is very important, and that is the presence of tricuspid regurgitation and the progression of TR after mitral valve surgery. This data is from a paper which was published many years ago, but still probably holds true to a large extent. You can see that many patients still or have significant degrees of tricuspid regurgitation, severe or moderate, after a long follow-up period. Many patients progress with respect to TR, and that can be a problem late in patients who were operated with prosthetic valves. What are the predisposing factors? First of all, the degree of tricuspid regurgitation in the first place. So, in principle, you should operate TR in addition to the mitral valve if you have at least moderate TR, but probably also if you have mild to moderate TR, especially in the young. Pulmonary hypertension plays a role, so if you have pulmonary hypertension, you have a highly likelihood to develop TR in the long run. Annual dilatation, specifically a diameter of above 3.5 centimeters. The concomitant implantation of a pacemaker, so the pacemaker leads are not good for TR, and the presence of atrial fibrillation. Here's an example of a patient who has aortic and mitral valve prosthesis, and this patient also has severe, significant TR.
So in summary, despite the fact that prosthetic valves have greatly influenced and impacted the treatment of valvular heart disease, there are still a number of complications and problems associated with prosthetic valves which are unsolved. And we haven't even touched the entire issue of hemorrhage due to warfarin therapy. Maybe future models and newer therapeutic agents for anticoagulation will solve some of these problems. We'll just have to wait and see.